Good evening, everybody, and welcome to the webinar Unveil the Breakthrough Dual Power of Elobixibat, the first in class with pro-motility and pro-secretory properties for the treatment of chronic constipation in adults. Our agenda for today will be introduction by me. I'm Dr. Pragati Srivastav, the medical advisor for Dr. Reddy's lab, constipation management, including the unmet needs, and introduction to Elobixibat by Dr. UC Ghoshal. Dr. Omesh Goel will then be talking about the clinical trials on Elobixibat, sorry, the Indian and the global perspectives. We will then have the question answer session and the vote of thanks. If we talk about chronic constipation, it significantly impacts the quality of life for many adults. There are many available treatments also, but they usually and typically focus on a single mode of action. This often leaves the patient with unmet needs and lack of satisfaction, as these treatments may not provide comprehensive symptom relief. Elobixibat, as the first-class bile acid transporter inhibitor, stands out with its dual mechanism of action of both pro-motility and pro-secretory, which offers a significant advancement in the treatment. This webinar will explore why Elobixibat represents a breakthrough in chronic constipation management and is also backed by the clinical evidence that demonstrates its efficacy and safety in improving the patient outcome. We have with us today two eminent speakers. Dr. Uday C. Ghoshal, sir, is the senior consultant and chief at luminal gastroenterology and GI motility at Apollo Multispeciality Hospital in Kolkata. Sir has experience of more than 40 years with more than 500 publications and more than 30 awards and oration under his name. He is the founder member and the Secretary General of Asian Neurogastroenterology and Motility Association. Sir is also the member of editorial board and peer reviewer to various national and international journals. He is the national coordinator of Indian Society of Gastroenterology Task Force on Irritable Bowel Syndrome. Sir is also the chair of Epidemiology and Infection section of Asian IBS Consensus Team and the Asian Dyspepsia Consensus Team. Sir has also been part of various clinical studies as principal investigator. We also have with us Dr. Umesh Goel. Sir is the professor at the Department of Gastroenterology, Dayanand Medical College and Hospital at Ludhiana. He is the governing council member of Indian Neurogastromotility Association, has a vast experience in both diagnostic and therapeutic endoscopy procedures, has more than 50 index publications and 7 chapters in book under his name. He has given 56 oral and poster presentation at conferences. He is part of the editorial board member for 3 journals and has been a reviewer for 8 international and national journals. Sir has also been invited as faculty to more than 25 international and national conferences. His area of interest includes the functional gastrointestinal disorders, gastrointestinal motility, alcohol and viral hepatitis or cirrhosis, and metabolic associated fatty liver disease. I now hand over the baton to Dr. Ghoshal to take us through the presentation. Over to you, sir.
Thank you so much. It is a great pleasure to talk about the unmet need of constipation and how newer therapies, at least in the Indian context, may impact on management of chronic constipation. So this is the agenda of the webinar. I'll be talking about unraveling the complexities of chronic constipation, navigating the current treatment landscape, and I'll be also talking about little bit brief aspects of Elobixibat, which is the new entrant in the therapeutic armamentarium of chronic constipation in this country. The molecule was very much there internationally, but we are now going to have it in India. And subsequently, Dr. Umesh Goel will talk about some of the studies on Elobixibat in international scene and subsequently talk about the Indian data on Elobixibat. In fact, he has the experience on the first Indian study on Elobixibat. Subsequently, we'll have question answer session. What is chronic constipation? Let me tell you that about 2 decades ago in India, typically constipation was thought to be infrequent bowel movement. That means people thought if somebody is passing less than 3 stools per week, he should be called having constipation. But we realize this is a fallacious definition. Lot of people who suffer a lot really have poor quality of life because of their constipation problem. They will not be labeled as chronic constipation if you follow this criteria of less than 3 stools per week. Then how should you define constipation in India? This is the Rome definition now. It says if somebody is passing type 1 or type 2 stool according to Bristol stool form, then you should be called as chronic constipation. Typically, you ask the patient about their bowel habit during last 2 weeks. And if the patient says that the bowel habit, about 25% of the bowel that movement that occurred in last 2 weeks were either type 1 Bristol or type 2 Bristol, it should be called as chronic constipation. Here is the Bristol stool form. As you can see, type 1 is pebble-like, and type 2, if you join all these pebbles together, and type 3 is dry stool with cracks. Now, according to the Rome, type 1 and type 2 are the constipation defining stool, and they should be there at least in 25% of the bowel movement during a 2 week period. However, there are other symptoms which are to be taken into consideration. Which are these? For example, straining, sensation of incomplete evacuation, sensation of obstruction or blockage, maneuver to pass stool. For example, digital maneuver, that means somebody is using finger to take out stool from the rectum, and pelvic floor support. Now, all these, they are definition of constipation. So you must not go by stool frequency alone, because the Western bowel movement is about 3 per week or more is considered normal in the West. But in India, 60% of the people pass one stool a day, and another 30 to 35% pass 2 stools a day, and therefore the Western bowel habit cannot be applied to Indian population. If somebody is suffering for more than 4 weeks with constipation, we call this as chronic constipation. And chronic constipation can be primary, which can further be normal transit constipation, where colon is moving normally, which I'll talk about later. Slow transit constipation, where there is a slow movement of the colon, and defecatory disorder, which occurs because of lack of adequate relaxation of pelvic floor during attempt at defecation or inadequate generation of intra-abdominal pressure. Secondary constipation include those which are due to anatomical alteration, for example, stricture in the rectum or colon, or medication such as constipating medication. Now we talked about type 1 and type 2 stool being the constipation defining stool. But we all know that Indian population pass losers too. The reason is we have a rapid gut transit time. We eat a huge amount of dietary fiber every day that leads to a lot of stool bulk. And third thing is almost 70 to 80% of Indian are lactose malabsorber, or they have milk intolerance. and the lactose is regularly taken by us, and therefore what happens is the stools are looser and bulkier. If you apply the Rome definition, which says only type 1 and type 2 Bristol stool form are constipation associated stool, almost 50% of the constipation patient will not be called having constipation. So therefore, there have been multiple studies, both from India and other Asian countries, particularly Korea, which showed that if you include type 3 stool as well as constipation defining stool, your sensitivity to diagnose constipation will increase. Therefore, this is what we suggest that type 1, type 2, and type 3 stools are constipation associated stool. Another issue is ask your patient, does the patient have only constipation or also have abdominal pain? If the patient has constipation as well as abdominal pain, particularly at least once a week, which gets relieved by passing stool, this patient is having irritable bowel syndrome, constipation predominant type. On the other hand, if somebody is having only constipation and no pain, this patient probably have functional constipation, or their diagnostic category is functional constipation. So you can define now or classify now constipation as IBS constipation, where pain is a prominent feature in addition to constipation, or functional constipation, where pain is lacking. You can see the diagram on the right side, the cartoon picture. Here, the lady in the bottom is showing abdominal pain or indicating abdominal pain. This is to depict to you that IBS-C may be commoner in female than in male. On the other hand, you see on the top, there is a man who is bothered about his bowel habit but doesn't have much abdominal pain, and this is functional constipation. So functional constipation would be commoner in male. And what is the driver behind? The driver behind is visceral sensitivity. That means those who have visceral hypersensitivity, in addition to constipation, they will have pain, whereas those who do not have visceral hypersensitivity but has only constipation, they will not have pain. And if we are looking at any therapy that should target this patient population, help this patient population, we want this therapy to not only relieve constipation, but also improve the visceral hypersensitivity. How common is chronic constipation in India? We have now multiple studies, at least 4 studies. Of these 4 studies, you can see 3 studies show that in the Indian population, 8% to 17% people in the community suffer from chronic constipation. Now, there was a study from our group in a rural area in Uttar Pradesh where we found the number of people having constipation in the population was low, but we have an explanation for that. And this is an outlier. So you can sort of consider this study as an outlier and do not take this data exactly to calculate the frequency of constipation, because in this study, we did not include functional constipation patient. Our inclusion criteria was they had to have IBS first, and then they were classified further whether this is constipation predominant IBS or it was diarrhea predominant IBS. Therefore, this is an outlier by design. So I will tell you 8 to 17% people in India suffer from chronic constipation. Another issue here is this is a study that showed that a large proportion of patients with constipation have self-perceived constipation. That means they do not fulfill the criteria of Bristol stool form or stool frequency or other bowel related symptom, but they feel that they have incomplete evacuation, and this is a large majority. And when we are talking about therapy for patient with constipation, this population has to be treated differently than patients who have real true constipation. Now, what is our treatment goal? Primary goal is improvement of symptom. Secondary goal is having at least 3 stool per week. This is a Western goal, but in India, we want at least 1 stool a day. And we want stool form should be type 4 without strain. We want that the patient should have overall improvement in the quality of life. I told you a lot of these patients have overlap disorder. These patients, they not only have constipation, but also they have upper GI symptom, and the overlap is as high as 60 to 70%. And the upper GI symptom may be secondary to lack of opening of the bowel and therefore secondary slowing of the motility. Further, many of these patients think that high fiber diet will benefit them, and truly speaking, high fiber diet may actually increase bloating and gas, and that may lead to inappropriate therapy with proton pump inhibitor. And if you move the bowel, some of these upper GI symptoms will also improve. Now, how to manage these patients. This is really a busy slide, but let me tell you, if you are in clinic practice and not in secondary or tertiary care, follow the algorithm on the left side. This is Indian Neurogastroenterology and Motility Association consensus supported by Indian Society of Gastroenterology. You first define, does the patient have chronic constipation? If it is chronic constipation, if he or she has chronic constipation, look at alarm symptom. If alarm symptoms are present, for example, blood in the stool, unintended weight loss, family history of colon cancer, onset in older population. Now, all these patients must receive adequate investigation before managing them as patient with functional constipation or IBS-C. Now, if alarm features are absent, then ask them a question. Do they have bloating as a predominant feature? If bloating is the predominant feature, then you should not give medicine that increase bloating, and I'll talk about those later. But if bloating is not a predominant feature, then you can go give those drugs. In our tertiary practice, we further investigate them for pathophysiology by doing a colon transit time, anorectal manometry, and balloon expulsion tests, which I may not detail because of shortage of time. Now, what are the principle of therapy? The principle of therapy are that we should give osmotic agent so that colonic water content is increased. For example, by giving osmotic laxative or the drugs which increases water secretion into the colonic lumen. Bile acid can get reduced in patients with chronic constipation. And if you give a drug, for example, Elobixibat, now this is an IBAT inhibitor, which I'll be talking about later, the bile acid will increase and it will cause catharsis. Methane production can cause constipation, and this patient may benefit from rifaximin. If somebody has low motility, often it is secondary to serotonin, and their prucalopride will work. And if somebody has fecal evacuation disorder, treatment is biofeedback. But let us look at what are the advantages and disadvantages of this drug. For example, look at osmotic laxative. What are the advantages? These are only osmotic agent, and they are even safe in pregnancy. Therefore, safety-wise, they are very good. They are entirely locally acting, and therefore they have proven safety on long-term use. They improve stool frequency as well as consistency because of their osmotic effect, and the effect lasts as long as they are taken. They are effective, low cost, and looks like natural therapy. But what are their drawback? Drawback is bloating. If these patients often report bloating, and now if you add all these agents to them, the bloating can increase. So therefore, if a patient complain of lot of bloating, I really don't give them these agents. Bloating and abdominal distension is the other feature. In addition, if you are giving magnesium based osmotic laxative, it can cause hypermagnesemia, and in patient with chronic renal failure or heart failure, you should use these with caution. Now, there is a class of stimulant laxative, for example, sodium picosulfate, bisacodyl. They are typically used for acute constipation and as rescue therapy rather than long-term therapy. They exhibit an anti-absorptive secretory and prokinetic effect, but they may not be always recommended for long-term use, and some patients may report having more abdominal pain because they increase motility quite strongly after using them. Now, what about mineral such as saline laxative? How about saline laxative and mineral oil? Sorry for the mistake here. This is mineral oil. So mineral oil and saline laxative, they're effective, low cost, and looks like natural product, but they should be used with caution, as I told. And what about prokinetic? For example, procalopride. Procalopride have proven safe efficacy, but their safety, though, is very good, and compared to the cisapride, they do not cause much QT prolongation. But in elderly population and with comorbidities, one should be careful. You should always do an ECG before starting this drug in elderly people. You should use half dose, such as 1 milligram, and while on treatment, ideally, they should also get a follow-up ECG for QT prolongation. They are not often used very long term. Current safety data suggests they can be used up to 24 months, and as the time passes, their efficacy may reduce. Some patients may have depression, suicidal thought, and they should be used carefully in chronic renal failure patient. And other thing is that they are excreted in urine, and therefore renal failure patient, you should not use them. So what is the unmet need in this patient of chronic constipation? Whatever armamentarium we have in market, they are not fulfilled. Every patient do not respond to them. If you look at the data, ultimately 50 to 60% patient respond to these drugs. Also, they have side effect. Some of the drugs are quite expensive, and some of the drug on long-term use, there is a development of tolerance. And this is a study that we did in Asia. What we did is we took all the patients of functional gastrointestinal disorder called disorder of gut-brain interaction now, and we asked them whether they were satisfied with the therapy prescribed to them. To our utter surprise, we found almost 50% patients, in spite of lot of therapies being available in Asia, were dissatisfied with the treatment. And interestingly, if you see the bar diagram at the bottom, the most patient or majority of patients who were dissatisfied, they had constipation or IBS-C. So among all functional gastrointestinal disorder or disorder of gut-brain interaction, it is the chronic constipation and IBS-C which need better therapy, because they are the one where the treatment is less effective and they are most dissatisfied. So this data clearly shows you there is no doubt there is a lot of unmet need in patients with chronic constipation. Now, will the Elobixibat, which is going to come to the market, fulfill some of the unmet need? Look at the mechanism of this drug. What this drug causes is, there you all know that bile acid, 95% of it actually is reabsorbed from the distal small intestine. This is called enterohepatic recirculation. And the bile acid absorption is inhibited by Elobixibat, because how bile acid absorption occur in the ileum? There is a molecule called IBAT, ileal bile acid receptor or transporter, ileal bile acid transporter. And this transporter is blocked by Elobixibat. Therefore, enterohepatic recirculation of bile acid reduces. So you get more bile acid to be there in the bowel lumen. And in fact, about 3 to 4 decades ago, I remember that one of the strongest drug that used to be used in the primary health center in a village where I used to live was bile acid, tablet of bile acid. It was a very strong cathartic. But the problem of this bile acid as it is very bitter in taste. And therefore, the compliance of the patient used to be poor. Here, Elobixibat will not be bile acid. The taste problem is not there. It will block the enterohepatic recirculation of bile acid. It will increase the bile acid in the bowel lumen, and therefore, I suppose it will be quite effective. And whether it is effective or not, the evidences Dr. Omesh Goel will provide you now. But let me tell you, this drug has two mechanisms of action. One is it is an osmotic agent which increases luminal water or osmotic substances. And second is in large doses, actually, the bile acid is a stimulator of motility. And third is when you have a lot of water and osmotic agent in the lumen of the gut, this also stimulates the motility of the bowel. The same is shown here pictorially, and therefore Elobixibat, as summarized in this table, compared to all other agents, do not have a single mechanism of action, but multiple mechanisms of action as stimulator of motility and osmotic agent, and also it reduces pain sensitivity or visceral hypersensitivity. So this table further summarizes whatever I have said. It doesn't have so much tolerance in the long run. It doesn't cause electrolyte disturbance. It is locally acting. It is safe in elderly. It has diabetic safety. It has cardiac safety. It has renal safety, though it may cause some abdominal pain in occasional patients. Therefore, look at the Indian constipation consensus. We said in that consensus that the patient of constipation who are most dissatisfied need top-down approach rather than step-up approach. Currently, all the physicians are doing step-up approach, and therefore the patient are dissatisfied. We need a top-down approach. And let us listen to Dr. Omesh Goel to Dr. Omesh Goel about data on Elobixibat, the scientific evidences. Thank you so much.
Good evening, everyone. After this masterly talk by Ghoshal sir, very nicely explaining the pathophysiology of constipation and all the drugs, available drugs, the unmet needs, the mechanism of different drugs. As you must have seen that there are many drugs available, but most of them act at different pathway, a different mechanism, and they all have their own limitations. And the unmet need, as rightly pointed out, is there, and as shown in the multi-center study in Asia, up to 50% patients are unsatisfied with their treatment of DGBIs. So here we explore the new drug, and we go into the data of this drug in the Indian and the international setting. So my first slide shows the two studies, the initial studies of a phase 2 studies which were conducted in Japan, where this drug was initially launched. And in the first study, we see it's a double-blind, placebo-controlled trial, including 133 patients with chronic constipation, defined by the Rome 3 criteria, which were available before that period when the study was conducted, and now we have the Rome 4 criteria. This drug was given for 2 weeks in this study, the study one, and the dose used was 10 mg per day with versus placebo. And the primary endpoint was the frequency of SBM, means spontaneous bowel movements, and CSBM used in some studies is complete spontaneous bowel movements. And the BSFS is the Bristol Stool Form Scale, which I'll be showing in the subsequent slides. What do you mean by this? And Ghoshal sir has already discussed that. The second study included 340 patients with chronic constipation. This was an open label study. That means there was no placebo. All the patients knew what drug they are taking. Because this study was mainly for the safety and long-term safety outcomes, and it was open label 1 year study in which Elobixibat was used in 3 doses as per the patient response of 5 mg, 10 mg, and 15 mg per day. If you see on the left side of this panel, the report from the first study showed that the time for spontaneous bowel movement within 24 hours was up to 86% patients had their spontaneous bowel movement within 24 hours. These were those patients who had SBMs of less than 3 per week. But after this drug, up to 86% responded within 24 hours. And the patients' complete spontaneous bowel movements, 46% were there, those who reported the complete evacuation of the bowels. The median time to first SBM was 5 hours, and the median time to first CSBM was 9 hours. And these all were, if you see this bowel movement, the consistency of bowel movements improved from 1 to 2 to 4.3 with this Elobixibat use, and the proportion of responders of CSBM SBM per week in the first week was 94%, and in the second week was sustained to 92% in the Elobixibat arm compared to around 50% placebo arm. The constipation severity also improved significantly with Elobixibat use compared to the placebo use. If you see the quality of now, the second important thing, as pointed out, always that after symptoms, it's the quality of life. How does the patient is satisfied with the drug, with the symptoms? So as the studies were carried out in Japan, so we have the Japan quality of life questionnaire scores, which were significantly better after Elobixibat use compared to placebo use, because the patients had SBMs, CSBMs, and pain relief. So they were really satisfied with their treatment compared to baseline. And now comes the data on how safe is this drug, because we always scared of a new drug which may have some major side effects, as pointed out by Dr. Ghoshal, that prucalopride, which is a pretty safe drug otherwise, but in elderly, especially more than 70 years, it can cause QT, prolongation, and even cardiac deaths. So we are always scared of any new drug which comes in the market, that what side effects do we have. This is heartening to note that this drug does not have any severe ADAs, and the most common ADAs, whatever reported, is just abdominal pain and diarrhea, which typically resolved in 1 to 2 weeks in the multiple clinical trials in which it has been used. And of the diarrhea cases, is because once the drug is used, the patients are very troubled with constipation, and we assume that once they have diarrhea, it's a sign of relief to the clinician and the patient that yes, the drug is working and the patient has emptied his bowel after such a long time. And in 61% patients, the diarrhea resolved without any dose changes because it was the initial drug effect. And in 25% patients, it required some dose reduction, but it was never troublesome. It never continued for long. And there were no deaths, no severe adverse events, even till 52 weeks of the study in which it was used for such a long time. And the primary elimination of this drug is through feces. So, and only 0.01% is excreted in urine. That means it's absorbed to such a little extent that it does not enter the circulation, and so it has a negligible risk of any side effects. It doesn't go into the bloodstream, doesn't go to any other organ, doesn't affect any heart, liver, or kidneys. So it is pretty safe in that context. Then there was another study. We know constipation, the chronic constipation, most of the patients are elderly. They are really troubled. They have constipation for many years. So there's always a concern with the new drug, whether it will work in elderly, whether it's safe to use in elderly. So this study was carried out in elderly patients of 65 and 75 plus ages. and luckily the response was as good as in the younger ages. The CSBM and SBMs were remarkably improved. The Bristol stool form improved from 1 to a median of 3 or 4, and the incidence of ADRs were also just marginally higher than the in other age groups, but it was significantly less. It was just less than 5% patients had some reported ADRs, and the ADRs were again diarrhea and abdominal pain, which resolved within a few days of decreasing the dose or even without decreasing. Other things, some people had distension or nausea, and no severe adverse events, no cardiac events, even in elderly. And this is a study which explored the rectal sensory thresholds. As we know, the patients of chronic constipation do develop a megarectum. They do not feel sensation of the stool in the rectum, and some of slow transit constipation, they don't have the stool even doesn't reach the rectum in such patients. So with this drug, when the stool frequency improves, when the stool reaches the rectum, stool is softer. We saw in this study that the sensory thresholds, the sensation of first sensation, the defecatory threshold, and the maximum tolerable volume all improved with Elobixibat compared to placebo. Now, if you see in various comorbidities, what is the data of the safety of this drug? First, we see in the diabetes group, the incidence of adverse events was just 3%, and that was also mainly diarrhea. No other major adverse event, and the quality of life improved, and the SBMs improved to 6 per week compared to less than 3 per week before starting therapy, and the Bristol stool form became normal, that is 4 and 5, as you said, are normal. So there's a really good safety in diabetic patients. In renal disease patients, also the incidence of adverse events was just 4.7%, and the incidence of diarrhea was 2.3% only, and the uh, SBM per day was 1.1. In heart failure patients, 17% reported AEs, out of which 11% were diarrhea only, and the SBMs were good, around 4 to 5 per week. In cancer patients, few studies have been done. It showed the AEs was just 6%, diarrhea just 1%. Only in Parkinson's disease, the risk of AEs is higher. The total adverse events are 55% and diarrhea is 28%. But the SBMs are too good, around 6 per week. So in this, you have to use with some caution. Otherwise, it's pretty safe in diabetics, CKD, heart failure patients. Now we come to the results. Now these were all the data done in Western populations or the Eastern population, like in Japan, where it was launched. And now this study was a phase 3 study to evaluate the efficacy and safety of Elobixibat in Indian patients, Indian constipated patients, which was done around 1 year back. And luckily, our center at DMC Ludhiana, we were a part of this study. This was a double-blind study. That means neither the patient and nor the investigators knew about what drug is being given. So half of the patient received placebo, and half of the patient received this drug, and we did not know till the end of study which patient got what drug. The primary objective was this, to evaluate the efficacy of this Elobixibat in our population, Indian population, because we know that ethnicity affects the efficacy of drugs in various trials. So we took patients who are according to the Rome 4 criteria, which defines as chronic constipation of more than 6 months duration, SBMs of less than 3 per week. The patients who were passing stools less than 3 per week without any medication. And the other criteria as per Rome 4, that is straining, lumpy stools, sensation of incomplete evacuation. And the treatment duration was 2 weeks. The drug was given for 2 weeks, and one arm, as I told, was given this drug, and one was placebo, which was blinded. And we were told to give tablets to the patients, and each tablet was supposedly of 10 mg, and two tablets were given. 2 tablets of placebo or Elobixibat were given, and after 1 week, we used to call the patient and ask the stool pattern. In patients in whom the stool frequency had not improved, we used to give 1 tablet more. That means if the patient had Elobixibat, the next week he received 15 mg of Elobixibat or placebo. In the patients who had diarrhea after the use of this drug, so we were allowed to reduce the dose to half, that is 5 mg, or even stop the drug. And I'll discuss how many patients had diarrhea. So if we see the median time to first spontaneous bowel movement was 11 hours in patients compared to placebo of 22 hours, and the median SBMs within 24 hours was quite higher with Elobixibat. Median more number of, like 51% patients had spontaneous bowel movement within 24 hours after use of this drug compared to a significantly lower amount with placebo. Then if we count the weekly SBMs in the Elobixibat arm, this is all the it was 3.8 compared to 2.7 in placebo. And if you see the complete spontaneous bowel movements, the number of patients, the percentage of patients having complete bowel movements were around 50% in Elobixibat compared to only 27% in placebo. Now, the most important thing again, as I told, the side effects in Indian patients, they were really not very high. Total 15% patients had some side effects, and there was no severe adverse events, no hospitalization, no cardiac or any other side effect. The most common side effect was pain, around 8% patient, which resolved with conservative management. Diarrhea in 1.32% patients, abdominal distension in 4%, and dry mouth in 2.6% patients. So overall, we can say that this drug was very well tolerated in Indian people and with no major adverse events. Now, coming to some additional data on this drug, after knowing this major big trials in Western Indian populations, I want to discuss few more studies. That what about the dose escalation? Now, as I told, in the patients who do not respond to 10 mg, we know that 15 mg can be given. But what happens? So this data we come to know from this long-term 52-week study, in which with time many people started using 15 mg dose compared to 10 mg. 15 mg had a better response, and there was no notable increase in the incidence of ADAs after dose escalation, even after dose escalation. So that proves that the 15 mg dose is as safe as 10 mg. And again, the tolerability of 15 mg was shown in another study. It was a randomized phase 2b study to determine the dose in Japanese patients. And in this, we see that the efficacy of 10 and 15 mg were almost same. And while the adverse events were also not increased when they used the 15 mg dose. Then another study which evaluated the use of the reduction in the use of other laxatives, like the patients usually are on other laxatives. And so what is the data? When they use Elobixibat, can they reduce the dose of other things? Yes, this study very nicely showed that the proportion of patients using stimulant and saline laxative decreased significantly from the pre-index to the index date. Like 50% patients were able to discontinue stimulants or saline laxatives after 360 days of Elobixibat initiation. That is a significant finding because we see that most of the patients are dependent on stimulant laxatives, which we know have their tolerance, have their own adverse events on long-term use. So with the use of this drug, if we can stop those, and so the overall the side effect profile will reduce and the cost of therapy will also reduce. Then this study included diabetes patients with constipation, very small number of patients, 21, but it showed that it has some benefit in enhancing the glucose and lipid metabolic parameters after use of this drug when the patients are relieved of constipation, and has improving, that means improved metabolic syndrome also, but we need larger data to prove this. Now, there are no head-to-head trials comparing. Now, the question will come to everyone's mind that, no, so what is, how is it comparable with other drugs? So, head-to-head trials do come later. We do not have any head-to-head trials comparing Elobixibat with other drugs like sodium picosulfate, bisacodyl, but we have this network analysis in which the various drugs, in the results of various drugs in their phase 2b and phase 3 trials have been compared. And this network analysis shows that Elobixibat may be possibly superior because the network risk ratio of Elobixibat compared to prucalopride comes to 1.27, while it has a similar efficacy to bisacodyl, sodium picosulfate, which are stimulant laxatives. So that is quite a good thing to know that it is as efficacy as stimulant laxatives, and it does not cause major adverse events. Another comparison, if we see the number required to treat. So this NNT means the number needed to treat to cause one a good outcome. If we see the Elobixibat, the NNT is 3. That means we need to treat, if we treat 3 patients, out of 3, 1 will respond favorably to this drug. So if you see the NNT of this is superior, the lesser the NNT, the more effective the drug. So if you see with polyethylene glycol, the NNT is 2, while with lactulose, bisacodyl, ubiprostone, lenactotide, prucalopride, and velucetrad, the NNT is more than 3. So we can say that if we see this data, Elobixibat is possibly superior to almost all the drugs. the number NNT is less. And however, so we need customized treatment plans for each patient, which drug to use when, and according to the age, according to the diagnosis, according to the side effect profile, the comorbidities. So this is a very good addition to the already available drugs for chronic constipation. As Dr. Ghoshal pointed out, it has dual mode of action. It is safe, so it is a very useful and good addition to the treatment of to the basket of drugs available for chronic constipation. So I'll end my talk here.
Thank you so much, Dr. Goyal. Dr. Uday Ghoshal sir, if I can just ask you to give a conclusion before we move on to the question answers from the
Please
audience.
go ahead. Please go ahead.
Yeah. So, sir, do you want to give any comments before we move on to the question answers, or we can straight away move to the question answers?
You can straight away, but I think Dr. Umesh well covered the topic very well. And particularly, it is encouraging to see that he spoke about Indian data. That too, it was a randomized double-blind control trial. And I tell you, this is a good practice that all the sort of pharma organizations should do. Earlier, for DCGI approval, used to do studies, but those studies never saw the light of the day. It remains in a white paper. But once you do good quality studies and then we publish these studies, actually the data bank of the nation will increase. And this is what we want. And thanks, Umesh. Congratulations, Umesh, for completing this study.
Thank you, sir.
So, sir, one of the main questions that has been coming up from the doctors is how will you position Elobixibat? So, we have seen the algorithm. Sorry. So, how exactly and where exactly will you be putting Elobixibat in that algorithm? So, we can have
Very good
Dr.
question. Very good question. Let me tell you that I told you that constipation, practically speaking, are of two types. One is patient perceived constipation, but when physician ask them question, they find they do not fulfill the criteria for constipation. Now, this patient, I don't think Elobixibat is the best therapy because they are only reporting little bit incomplete evacuation and therefore they can be dealt differently. Much simpler medicine may be useful in them. On the other hand, in our practice, where we get patients who have really severe constipation, they come to us after jumping several ladders and now they have severe constipation. In those patients, I will not follow this algorithm. This algorithm is for the physician in practicing in the community, not the gastroenterologist practicing in tertiary center. There in first go itself, I'll give the best drug and gain the confidence of the patient until somebody suffers from constipation, he doesn't know how difficult problem it is. So question is, I will give the best drug. And when I say best drug, what we do is if it is slow transit constipation, I have two choices. One choice is procaloprid, and the second choice after the Elobixibat is in the market is Elobixibat. So I'll not give other drug. I'll give either procaloprid or Elobixibat in slow transit constipation. Now, fecal evacuation disorder, maybe neither will be great. Now, there, obviously, you need to give biofeedback. You can give additional therapies with one of the agents, such as Elobixibat or procaloprid. So, once they respond to Elobixibat, I'll reduce the dose. Same is true for procaloprid, but in my clinical experience, once somebody respond to 2 milligram procaloprid, you reduce the dose, they fail to respond often. So therefore, in case of Elobixibat, based on the data that Omesh presented, I think even lower dose will save money and will give them satisfactory bowel.
Thank you, sir.
I completely agree with Kushal sir, because I mean, this drug, I mean, when the experience what we had in this clinical trial, the patients who responded, they responded within even the first dose, because this drug doesn't need time, more time to act. I mean, almost, so the response was around 70 to 80% patients who did pass Proctor's tools within the first 1 to 2 days. Obviously, with each drug, you don't have all responders. So 20 to 30% patients did not respond that well. And but the patients who did respond, they were so thankful to us, and that they were so like a blocked drain had opened up. So they were so happy and thankful, and it really works. And titrating the dose, and patients who had diarrhea, I will just reduce those to half, and they were again happier. And so titration is so easy because it works on day-to-day basis. So titration of the drug is so easy, and no major problems we face.
Thank you, sir. So, Dr. Goyal, because you have used the drug, one of the questions that also has come up is about meal dependency and the time for giving the drug. Is it in the morning or the night? So, if you can put some light on that.
So as we saw, the median time to action was 8 to 9 hours. So what I would prefer is give it at bedtime, and the patient wakes up in the morning, clears his bowel. I mean, because various studies have shown the median time to act was around 8 to 9 hours. So there, obviously, when bile acids do come after meals only, but even after dinner, the patient takes it and sleeps, and the morning wakes up and he passes a stool. That is always good for the person, because most of the patients have to go to work and they don't want to go to that stool for the workplace. So that I would suggest best Dr. Kushal sir can add to that.
Dr.
I
Vishal.
agree. Yeah, I agree. Some drug, for example, plicanatide, you give in the morning, because the time for action is very short. On the other hand, here, as Dr. Omesh said, median time to act is 8 hours. So therefore, we'll give in the bedtime.
One more question is that when we talk about constipation, the word or the thought that comes into mind is elderly patients and patients who have comorbidities. So, what has been your point of view on these points? So, we are talking about patients who are having polypharmacy. So, they have so many other drugs that they have to take. So, how has your experience on it?
So actually, in this trial, I think we were not allowed to take patients who had significant comorbidities. But if you see the mechanism of action, this drug is not absorbed at all, and it doesn't act through any cytochrome pathways. It doesn't have any hepatic or renal excretion. And we already saw the safety data in cardiac patients, diabetes patients. So I think it can be used in almost all the patients, except those Parkinson's disease. We would need more data. That is a very extensive disease actually. But in all the other comorbidities, and especially in elderly, as I pointed out, this is pretty safe drug in which we have problems with paliperidine because of QT prolongation and cardiac side effects. So this drug would be very safe to use in almost cardiac,
Yeah.
diabetes, elderly, and CKD patients.
Yeah, I think there is a very important point here. What Elobixibat is doing is that this drug is removing more and more bile acid from the gut. Now, when bile acid is lost, obviously liver will synthesize bile acid, because normally liver doesn't work so much to produce more and more bile acid, because it is getting recirculated. Now, when liver produces more bile acid, where from does it produce? It produces from cholesterol, because bile acid is synthesized from cholesterol. And this is the mechanism of excretion of cholesterol from the body. And therefore, what happens is hyperlipidemia patient will benefit. You may find after some time the patient may not even need hypolipidemic drug, because the Elobixibat itself is removing the bile acid, and more cholesterol has to be converted to bile acid. Interestingly, Dr. Omesh shared you a small study where even HbA1c improved. Now, maybe some relationship is there between HbA1c and bile acid, and that's why it improved. Obviously, you need more data. So, therefore, diabetes, which is a very common problem, hyperlipidemia is a common problem, and these are together called metabolic disorder. show the metabolic disorder in general will improve with Elobixibat. And probably same is true for fatty liver. Because when you give something which need to more bile acid excretion, maybe fatty liver will improve.
Thank you, sir. One more question that we got was, what about the use of Elobixibat in patients who have had cholecystectomy? Is there any point that we need to keep in mind for such patients, or will the treatment be same as what we do for the normal patients?
I don't think there is data on this,
Yeah.
but cholecystectomy patient, if they have some GI symptom, I more often find diarrhea in them. And I suspect bile acid diarrhea in this patient. And I give a bile acid binding agent such as cholecalciferol or cholestyramine. Now, whether Elobixibat will interfere with it, yes. If somebody has diarrhea, don't give Elobixibat because what may happen is diarrhea will increase. But if somebody has constipation, it may not interfere much. If after cholecystectomy he has bile acid more in the bowel, still is having constipation, he needs more bile acid for catharsis.
Dr. Goel, your points on this?
Yeah, I fully agree. I fully agree. Most of the patients also this have diarrhea. Actually,
Yes.
they already have bile acids and they mostly have diarrhea. If they have constipation, still we can use this drug and try. If it doesn't act, we can shift to other drugs.
And sir, in case of hepatic disorders, like we are talking about the bile acid, which is very much related to the liver. So, in case of patients who are having some sort of liver disorders, how exactly will you think there will be effect on the treatment of constipation with Elobixibat? Or if there is even an bile acid obstruction for the bile acid flow?
Yeah, I told you possibly that may be beneficial because more bile acid is getting excreted, but obviously we need more data on this.
Yeah.
But pathophysiologically, I suspect it may be better to use Elobixibat than other drugs.
So, is there any group of patient where you would say that yeah, we need to have some caution for the use of Elobixibat in your, I mean, in the clinical trial, if you have seen anything, Dr. Goel?
Yes, I mean, the advanced liver disease patients, we may have a phase 4 study. Other disease, I think we are pretty already. We have good data for diabetes, CKD, and heart failure patients. And advanced liver disease, yes, we child B and C cirrhosis. Maybe we can say we need data on that to just see what happens in those patients. Otherwise, neurological disorders, as we see Parkinson's disease, all this can be seen in phase 4 studies, I think, later on. But beside these two things, all other things are already favoring this drug use in these comorbid patients.
Thank you, sir. Dr. Ghoshal, any points from your side on this? Any
Yeah,
caution?
no, I do not have any other comment on what Dr. Omesh said. It is well accepted.
So, considering that we have a time is nearly over, so just wanted some sort of your point of view on usage of the drug, Dr. Goel, and Dr. Ghoshal, your point of view on Elobixibat as a whole. If we can have Dr. Goel first.
Okay, again, I think everything has been discussed, but just to summarize, this is a pretty safe and efficacious drug. It looks like in all the trials, and in the larger phase 4 trials, again, or it can be, I mean, used clinically in almost all the subgroups of patients, especially the more troubled patients, the elderly patients, the cardiac, renal, and the diabetic patients. It is found to be safe and efficacious. So, I mean, as Ghoshal sir said, we can use it as second or first line level even when the patients reach to a tertiary care center. They've already taken all the drugs. So it may be that we might be using at a first level of contact with the patient because they already have exhausted their list. And it's a wonderful addition to the basket of drugs.
Thank you. Dr. Ghoshal, what about the future of Elobixibat according
Yeah,
to
you see that I told you data clearly so. And I tell you, all those who are listening to this presentation, they also from the experience will agree with me that of all the functional GI diseases, most difficult to treat is chronic constipation. So there is a tremendous unmet need in that area, both substantiated from data as well as from experience. Now, any agent which is found to be very effective in the current therapeutic armamentarium, which are not there today in our country, we welcome them because we are in need of better therapies in chronic constipation to relieve our patients. Elobixibat obviously was there, available in Japan for long time, and now it is coming to Indian market. Mechanistically speaking, it is likely to be a good drug. And when I listen from the experience of Dr. Omesh Goel, I'm also encouraged to see that it appears to be a good drug. Number needed to treat from network meta-analysis was much lower for this drug than many other drugs. Only thing is that which patient, which therapy will benefit most, there may be variation. I may get occasional patient who don't respond to Elobixibat but respond to another drug. But there obviously as your clinical experience increases, you will do better. Sometimes we may have to do switch therapy. Let us say I'm giving somebody plicanatide or procalopride. He's not responding. I switch to Elobixibat and I find he's responding, and vice versa. More will come as our experience grows. But this is a good drug from scientific aspect, mechanistic aspect, and we are happy to see it to be there in the market.
Thank you, sir. So in short, if I can see, there are three major boxes for chronic constipation: efficacy, safety, and satisfaction. So I guess Elobixibat ticks all the three, and the data shows the same thing. But yes, as you said, we need to wait for the real world to understand how exactly it is working. So thank you so much for joining us today on a Friday evening, and thank you so much for the audience also. Do take care and have a great weekend ahead. Thank
Thank
you.
you. Bye. Good night, everyone.
Good night.
Right, good night.